Good morning. I'm Jessica Lovell, and welcome to the Morning Medical Update. One day, we hope there will be a way to cure all cancers. But until then, doctors and scientists are finding better ways to control cancer, whether that's preventing cancer in the first place or making treatment and survivorship much more manageable. Today, we are exploring a few areas where experts are seeing promise and progress in reducing the overall burden that cancer creates. When it comes to preventing cancer, see how many of these risk-reducing tips that you live by. Not using tobacco and avoiding secondhand smoke. Limit your alcohol or cut it out completely. Get the HPV vaccine if you're eligible, and make sure young relatives get it too. Protect your skin from the sun with hats, long sleeves, and plenty of sunscreen. Are you maintaining a healthy weight? And stay on top of your screenings like mammograms, cervical exams, and prostate and colon exams. And of course, see a doctor at least once a year to help you keep on track of what tests you need. So let's dig a little deeper into it today with our guest. We have right here in the center, Dr. Lauren Nye. She is a breast oncologist and the medical director of breast cancer prevention at the University of Kansas Cancer Center. Shobhana Kubendran is a board-certified genetic counselor, and she is the manager of the health system's genetic counseling service, an area of cancer care that really is exploding in demand. And we're going to talk more about that. Joining us remotely is Dr. Christy Brown, who co-leads the Cancer Prevention and Control Program at the University of Kansas Cancer Center. She is in San Diego with us this morning now for the annual meeting of the American Association for Cancer Research. Dr. Brown, that conference started over the weekend, and it's just great to know there's this big meeting of the minds out there, a bunch of cancer experts all gathered in one place. What has been the highlight so far?
Oh, there have been so many. I think there have been, some exciting advances with regards to our understanding of how metabolic health is influencing cancer risk and progression. There's also some interesting data with regards to the microbiome and how it influences risk of various cancers, but also how diet and diet modifications can act to reduce the risk of cancer. There have also been a number of highlights with regards to people's lifetime achievements and really showing how far we've come both in cancer prevention but also in cancer treatment. And it's actually really impressive to be seeing what has been done over the past few decades.
So help us understand this term cancer control. And it's not exactly the same thing as cancer prevention, correct?
That's correct. And I think a lot of what we do in cancer prevention and control is try to first understand what increases risk and then think about how we might be able to act in the community to be able to reduce that risk. So it's not only being able to find ways of reducing risk, but how do you implement that in the community? And it's not always easy. And if you think about Kansas, for example, with rural populations that don't necessarily have access to care as easily as in big centers, that becomes especially important.
Yeah, it brings on that additional challenge. One big area of research is in obesity and metabolism. There are clear links between excess weight and many types of cancer, including the ones that you see here on the screen. And we know diabetes is also linked to many types of cancer, and we know that obesity and diabetes are super common in the U.S. So what do we do about it?
Well, it's a tough question, right? We've been trying to approach this from a lifestyle intervention point of view, and in a clinical setting that's very controlled, this seems to be working. So we know that moderate exercise for at least 150 minutes a week will reduce the risk of cancer. But that's much harder to implement in the community. And I think that's where we need to become creative or innovative in how we approach this. And there are a number of ways that this is being done, still in a study level approach, where some studies have shipped out treadmills and have had very clear indications for participants to be able to control that weight. But with the advent of these new anti-obesity drugs, which are showing, a lot of promise with regards to reducing weight, which we think to an extent which will actually have an effect on cancer, I think there's a possibility that these may also have a really important role to play in reducing risk for all of these cancers and potentially others as well.
All right, let's talk about breast cancer. And first off, get your mammogram. We can't say that enough. If you've been putting this off, stop what you're doing right now. Schedule it. You can text the word mammo to 913-588-1227. Book it. Send that number to your friends. Get it on the books. And Dr. Nye, you're the medical director of breast cancer prevention here at the health system. How can we best reduce the risk of breast cancer?
So we've talked about a few of those ways that we focus on risk reduction, including exercise. You highlighted limiting alcohol, which is a really big one. And trying to achieve a healthy weight is ideal. Those are what I call the lifestyle factors that we can target to reduce our risk of breast cancer.
When would someone need chemo to prevent cancer? How does that type of chemo treatment work?
So I love that question because it's not actually chemotherapy that we use to reduce the risk of breast cancer. It is a drug or a medication that has been shown to reduce the risk of breast cancer. And most of these are current state anti-estrogen medications or estrogen blockers that reduce the risk of breast cancer by about 50%. And we do recommend them to women who are at an increased risk of breast cancer, somebody who has at least double the average woman's risk of breast cancer, which right now is around 12 to 13% lifetime risk is average. So anything double that, we would consider these medications for.
So how does someone know if they are at that high risk for breast cancer?
There are many ways to calculate a woman's risk of breast cancer. There's different calculators out there, but the first step is talking to your provider about your family history and your personal risk factors like breast density, if you've ever had a breast biopsy, or if you've ever had any trouble with your breast. That's a reason to talk to your provider and say, hey, can we calculate my breast cancer risk, or where can you send me to get my risk calculated? Many times it's done in mammography, so when you go and get a mammogram, they will calculate your risk. Sometimes that's reported depending on where you are, but most women should have their risk calculated 5 to 10 years prior to age 40, and so it's good to start having that discussion young.
So Shabana, how important is that family history? What can you learn from someone's, what we call a family tree, you call it a pedigree?
Right, yeah. So a pedigree is essentially a 3-generation family history. An important part of that is making sure you take both the affected and unaffected. So we take into account the family size, the number of individuals with cancer, the types of cancer, the age of onset, and also unaffected relatives, because that also comes into play when we do a risk assessment. So a family history is good in the sense that it gives us indicators like, based on this, there seems to be a hereditary predisposition. But the absence of a family history should not preclude anyone from asking for a genetic risk assessment, because there are, genetic testing is now a little bit more advanced, where even in the presence or absence of history, we can still determine whether a certain individual would meet criteria for testing. And then really a genetic counseling appointment is to discuss what is an individual's perception of risk for cancer, either based on medical history or family history, and then giving them the options of, here are the different types of testing panels that would be helpful.
So, Dr. Nye, in a perfect world, would you want everyone all your patients to know their family tree and their family history?
Absolutely, but I know that's not possible. Especially in prior generations, we didn't talk about our health. We definitely didn't talk about our breasts or our ovaries or things
You're
like that.
not talking about that at the Thanksgiving dinner.
That's correct. Many women used to hide their cancer history, and so many women don't know their family history, or they'll come in and say, my grandma had a female cancer, and that's okay. That's okay to bring those up. We'll work with whatever we have.
And we've come a long way. Remember we did this story where this group of women, they make it like an annual girls trip to get in the car and take a road trip to get their mammograms.
The mammogram, yes.
That must be music to your ears, and
Yes.
those stories, you love that.
So.
We're talking about it all the time, whether you want to hear about it or not.
Right. So to add to that, I might add, while I have this venue, we have studies that have shown, we have guideline-driven genetic testing, meaning if you meet this criteria, you get tested. But we also know genetic testing has found mutations in genes that we wouldn't have identified just based on family history alone. So it's useful.
Yeah.
very useful in interpreting, but those listening out there, don't let the absence or the discussion of family history stop you from asking for a genetic assessment.
Because I think that is something that kind of a buzzword, does it run in your family? Nope. Okay, so you kind of check that box and move on, and you feel like, okay, my risk is pretty low. So, I mean, and go a little deeper into that, because somebody comes in, meets with you, gets a genetic test. What kind of information do you provide that they can then turn around and actually lower their risk?
Absolutely. So part of a genetic counseling appointment is, the assessment of the risk perception and actually the calculation of what are the chances somebody would have a mutation. So, in general, broad overview, we categorize results based on, are they mutations in genes that are with a high risk of cancer, like BRCA1 and 2, which accounts for the vast majority of breast cancer, hereditary risk, and then you have moderate risk genes. So they increase, but not to the extent that it does as with a BRCA1 and 2. So there are different levels of risk surveillance that is done based on the type of the gene and the variant, the change in the gene. So that's where we look at the different types of panels and tailor it to the individual, because some individuals are like, tell me everything. All genes, high risk, low risk, medium risk, everything. And there are others who just were like, I have a lot going on. I just want to look at the genes that are known, verifiable, high-risk genes. So those are some of the different components of a risk assessment. And the other most important thing is people need to understand you can get three types of results. You can get positive, meaning it's a genetic change that clearly is associated with a risk of cancer. And then you have a medium gray result called a variation of uncertain significance, meaning it's a genetic change that has not been reported before. But what do you do with it? Like, you found a change, but it does something, but it's not, it doesn't have an actionable surveillance with it. So in those cases, we still do an individualized risk assessment based on the medical and family history, and then we turn over to the high-risk prevention clinic to...
That was my next question. What's next? You find out one of these three options, and then how are you communicating with high risk?
With high risk, yeah. We have the information based on the guidelines, whether somebody needs a bilateral mastectomy, increased screening with MRIs, but really to tailor that information. We have the guidelines, but to tailor that frequency of intervention, the mastectomies, we do work with our collaborators in the breast prevention clinic.
So how do you talk to young men and women wanting to start a family? We know you can pass on mutations or conditions, but what are those conversations like?
Those are so personal, because when you find you carry a genetic change, it almost feels like, did I do something? Can I pass this on? Is this going to affect my future generations? That sense of responsibilities, it tends to be unique in genetics compared to other lifestyle factors. And it's always a discussion of what does that result mean to you and everybody's lived experience with a condition. So there are those who adapt to that risk very well and those that struggle. So that's where I would like to say the counseling part of genetics comes in, where we really try to understand what is that individual's risk perception and how to adapt to that risk. So does that include pre-implantation genetic testing? Does that include, no, let the child decide when they get older? Because what are you going to do with that information?
An interesting time that there are choices. Back in the day, whatever that may be, the choices weren't there. So now you have it can be curtailed.
Right. And
to
really
each patient.
and really just having that discussion. If it's BRCA, we're not really doing anything in terms of breast surveillance or lifestyle modification below age 18. Or maybe there are, I don't know. That's a good question for Dr. Brown, if there's any research coming, on early interventions for cancer control.
Dr. Brown, any comments?
Well, I think it's important to highlight that there's interaction between all of these risk factors. So in thinking about, germline mutations and mutations in these genes that predispose to cancer, we've also shown that, having a higher BMI or someone with obesity is more likely to have damage in their normal tissues relative to someone who doesn't have obesity. So thinking about how that could influence individuals who are diagnosed earlier, with regards to maintaining a healthy weight throughout their life. And this kind of goes to some of the epidemiological studies that have shown that maintaining a healthy weight and an active lifestyle early in life actually reduces the risk of cancer in these individuals who are already at high risk.
So when we say genetics, most of us think of a hereditary condition being passed down from generation to generation, but there's also the genetics of tumor cells. Dr. Knight, how does the genetic information of the cancer itself inform your decision making as a doctor?
So it's been a really exciting decade, I would say, especially in breast oncology, where we're using the germline for some targeted therapies. We do have drugs that target germline mutations in BRCA1 and 2, but now we can look for mutations in the tumor. So if you think about what a cancer cell is, that started out as one of our normal cells in our body and accumulated these mutations or misspellings that allowed the cancer to grow uncontrolled and become a tumor, or what we call a cancer. And now we can identify what those mutations are, and we have drugs that target them that we can use to treat mostly metastatic breast cancer right now, but we're getting new drugs every year. And so somatic testing is what we call it, has become really critical to tailoring our therapy for patients with breast cancer.
So patients often get a tumor biopsy, and then that gives doctors valuable information to know, the treatment route. But there's also something called circulating tumor DNA. What is that, and can you use it instead of a biopsy?
So we can, and we do. You can have your blood drawn, and in that blood draw we detect either circulating tumor cells, circulating tumor DNA, and we can do our genetic testing on that sample. Sometimes we prefer a tumor biopsy if we can, but obviously that can come with risks. So in some settings it may be appropriate to do a blood test for those possible somatic mutations.
On a research aspect, Dr. Brown, what can you comment when it comes to circulating tumor DNA?
It's been an area that's been really exciting over the last 5 or 10 years, really understanding that, some of these tumors will shed cells and also shed some DNA that allows us maybe to detect some indolent cancers, so some cancers that haven't been detected yet. It's also been used as far as understanding response to various treatments. And now we understand how some of this DNA is packaged as well, and what does that mean from a biological perspective. So I think there are a lot of advances in that area. I hope that we can move forward and increase the sensitivity of the tests and the reliability of them as well, so that it can be integrated in a somewhat less invasive manner in the clinic.
We mentioned tobacco earlier, and we saw the headline last week that several medical groups are suing the FDA for being too slow to ban menthol products. Dr. Brown, why is that menthol ban important?
I think menthol cigarettes have, obviously they mask the taste of cigarettes. I'm not a smoker, but I know people who are, and it's something that actually makes it easier to smoke. It also affects or is taken up by populations differently. So underserved populations tend to be more likely to utilize menthol cigarettes. So I think this ban, or this effort to ban them, is working towards improving the disparities with regards to cancer as well. So I think this is an extremely important effort, and I hope that that this will go forward very quickly.
We mentioned the HPV vaccine earlier. It has the power to actually prevent several different kinds of cancer. Dr. Brown, what gives with this? I mean, are you frustrated when you see that most teens and young adults still are not getting it?
It's just one of those advances that we should be embracing, and there is clear evidence that the HPV vaccine reduces risk, and I think it's important to consider the uptake not only in girls but also in boys. So males are also able to transmit the virus. So the uptake is really, really important. The good thing is that, there are efforts towards putting this in place more broadly, and the NCI has really launched this initiative this year so that we can do at-home testing for HPV. So people will be collecting samples at home and then sending those in an effort to reduce the risk of cervical cancer. So I think there are still advances in this area ever since, we developed the Pap test to be able to detect this. So I think there's a lot going on in that space, and I hope that people will be taking this up as they should for other vaccines as well.
Well, be sure to ask your questions. You can use the chat on YouTube or Facebook. We are on the X platform, or you can email the Medical News Network. Info is right there on your screen. Let's head out to Olathe, get a COVID count from Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control. Good morning.
Hi, how's it going?
Hey, good. Happy Monday.
Good, yeah, happy Monday. The COVID count is not as good as it was last week. We had single digits. This week we are up to 12 active patients in the hospital, and we have 1 in the ICU as well. So, not the good trend we were hoping for. We had that one data point of a single digit admissions. So hopefully we'll see what happens this next week, and hopefully we can continue and really get a trend going down to continue in those single digits and maybe even down to 0.
Well, we like the sound of that. So, Hawk, we've been talking about cancer and cancer prevention today. A recent study confirms that the pandemic led to thousands of missed cancer diagnoses, something that doctors were very, very concerned about from the very beginning. And this CDC chart shows the number of new cancer cases rising year after year until 2020. On the far right, of course, the cancer didn't drop or go away, just the diagnoses dropped due to the delay in screenings and those missed doctor's appointments. So, Hawk, what did this study published in JAMA Oncology find? How did they prove this?
Yeah, I mean, they looked at, just like you showed, they looked at all those numbers, the data from previous years. So they looked at how many cancers were actually diagnosed, what was the change in those over all of the years, and then they had forecasts. And what they found was the forecast was much higher than what was actually diagnosed. It's otherwise fairly simple math and statistics, and it's consistent with what we've seen in the past as far as they took that concrete data and applied it towards future forecasts, and they saw that significant drop in cancer diagnosis. And what it's believed is because of the COVID pandemic and just the lack of people going in and getting their testing, and it wasn't because overall cancer diagnoses were dropping and people weren't getting disease. It was because really the lack of access, because people were home, because there was those shutdowns. Maybe some of the clinics were shut down. Just going to those normal visits that you would go to, not even for those specific cancer diagnoses, but even just going to your regular physicians. I know certainly in my family we were impacted by that as well. So, it was very real. There were, it was almost 150,000 cancers, which were probably missed because of multifactorial reasons, but during the pandemic where people just were not able to get to their screening as they should have.
All right, let's get to some questions from our viewers. And Doc Hawk, I'm going to stay with you. Why do I keep seeing these posts about turbo cancer? Is this really just misinformation? And what is that?
Yeah, I mean, again, this is one more thing that we've had to deal with during the pandemic at a greater level than we've ever had to deal with, and that is medical misinformation. Certainly, it really started with the disease itself and who it was affecting and who it wasn't affecting, and then you go on to false treatments such as ivermectin and hydroxychloroquine, which were championed by certain people, many groups, which just were proven to be false and actually led to more harms than there was good from taking those medications. This is one more thing. This is misinformation about vaccines, where people, for some reason, have the idea that people getting these COVID vaccines are somehow developing these cancers that are quickly moving or fast moving, these turbo cancers that lead to morbidity and mortality. There's absolutely no truth behind that. All of the vaccines we have on the market right now have proven to be safe and proven to be effective. And unfortunately, it's the state that we're living in. It is one more issue that we have to deal with medical misinformation, because it's all really not significant or really doesn't matter until it affects you or your loved one. But what we're trying to do as the health system, as medical providers throughout the country, throughout the world, is to try to promote the true information. Of course, be transparent with it, and it is out there for those people that do like to do their own research, but it's also trusting medical practitioners and scientists, those people that are dedicating their lives and their time to creating a safe environment so that we can give you the best information to keep you and your family safe.
Dr. Brown, are there other vaccines that can prevent cancer?
So there have been some vaccines in the Lynch syndrome space, so to protect against colorectal cancer. Clinical trials are still underway with regards to those, but I think they're showing a lot of promise. I'm trying to think of others, but I think that's probably one of the ones that will have one of the greatest impacts and is probably closest to being implemented into the clinic. I'd refer to maybe Dr. Nye to comment further, or Dr. Hawk, who we haven't had a chance to meet yet.
I think the HPV vaccine was our greatest vaccine to date, showing really decreases in cervical cancer and head and neck cancer. So not only does it prevent men from transmitting HPV, but head and neck cancer is a very difficult cancer to go through treatment for, and if we can lower the incidence of head and neck cancer through HPV vaccination, that would be an incredible achievement as well. So that is our greatest vaccine so far. Lynch syndrome, breast cancer has vaccines in clinical trials right now, but more to come.
Another question for you, Dr. Nye. We know that breast fibroids can be common. Does that mean you're at higher risk of breast cancer?
No. Fibroadenoma is a benign mass in the breast. It does not increase the risk of breast cancer. If we see atypical cells or something else reported on that, that's a reason to talk to your doctor about, does this mean I'm at an increased risk for breast cancer? But the fibroadenoma alone, no, but they can be bothersome.
Okay, so one of the biggest medical mysteries right now is why younger people are being diagnosed with certain types of cancers. Dr. Nye, what are your thoughts? And how far are we from really pinpointing what this is about?
It's really difficult to pinpoint environmental exposures on an entire generation of cancer diagnoses, but I do think there's a lot of things in our environment that we're exposed to, and minimizing those as much as possible, whether it is charred meat or microplastics or preservatives in our food, everything in moderation. Try and put whole grain fruits and vegetables on your plates and try and lead a healthy life, but you don't have to take it to an extreme.
But as time progresses, we have more and more things we have to start
That's correct.
keeping track of. New factors come into play all the time. Dr. Brown, did you want to comment on that? Just what your thoughts are on why we are seeing this come up in younger folks?
I think a lot of people are taken aback by these recent data as well, trying to figure out what it is. And I think exposures is definitely at the top of the list right now. But it's something that's actively being studied. So I hope that we can find better answers to be able to pinpoint what's going on and what we might be able to reduce those cancers.
Dr. Brown, what's the big takeaway from our conversation today?
Well, we have a real interest in metabolic health and how that influences cancer. I think, but it also comes down to, again, what we're putting into our bodies or what we're exposed to, and how we're keeping healthy. And I think keeping healthy weight, healthy lifestyle, not only affects cancer risk, but it also affects cardiovascular risk and diabetes. And all of these things work together to affect our lifespan. And so at the end of the day, being healthy and making healthy choices can have important impacts on our risk of cancer, but also on a lot of other things. Early screening or or screening for early detection is also really important. Taking preventative measures such as vaccines to be able to reduce the risk as well. I think all of these things work together towards being able to prevent the development of cancer and having to deal with, that diagnosis, which affects so many individuals at the moment.
Shabana, what's the takeaway? And I know you have some digits you want to share with us too.
Yes, I do. Thank you. Yeah, I have a team of 7 genetic counselors, soon to be 8, and the number for our clinic is in the chat box. And so please call us. We are here, genetic counselors are here as a trusted source of information on genetic testing. Coming for a genetic counseling appointment is not just about talking about genetic testing, but also discussing what does this genetic information mean to you? What does it mean to your family? What does it mean about passing it on? And what are the different pros and cons of testing and managing that risk? So call us because you will get an individualized risk assessment and also very detailed discussion of the type of test results that you just can't Google your way into. So that's why. So whether you have a personal or family history, but you have questions whether there is a genetic component to this cancer or a condition, call us and we're here to help guide you through that maze.
Well, and you said, you wanted to make sure you shared that so that people didn't have fear that it was going to take a long time to get through to you or that it was going to be a big, long process, that there's a number you could call and we're going to help you get in.
Yes, absolutely. And, just so you know, we schedule our appointments based on we call it clinical acuity, like based on the severity. So there's always somebody who's going to look at your referral. So we do require a referral from your primary care or a physician who's involved. But we look through that and then we, basically it's me, so I'm trying to see how soon you need to get an appointment. So please don't let a perception of wait time hinder you. There's a wait time in every aspect of healthcare now. But yeah, so call us and we're here to guide you.
Dr. Nye, what's the big takeaway?
Know your risk, and that's been all over the media lately, so I'm going to jump on that bandwagon. But know your cancer risk, and know if you don't have a genetic mutation, it doesn't mean you're not at high risk for cancer. And if you don't have a family history of cancer, it doesn't mean you have no risk of cancer. So just know your risk. Knowledge is power. Work on the lifestyle modifications to lower your risk of cancer, but know when to start your early screening and early detection.
Great information. Great conversation today. Thank you.
Thanks
to all of our guests for being with us today. We'll see you back here tomorrow at 8. Coming up tomorrow on the Morning Medical Update, Scott Seaton was one step away from donating a kidney. Then he found out he needed a transplant just as urgently. I'm Jessica Lovell on the next Morning Medical Update, the second chance that Scott calls his second life, using art to pay it forward. Tuesday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now everywhere podcasts are available.